All right, so let's turn it back over for questions, please.
Okay, so you have a question here?
Considering only the therapeutic effects of tricyclics, are they superior than SNRIs in treating pain? Considering, for example, nortriptyline and amitriptyline are both available in public services in Brazil. There's not been head-to-head studies that I'm aware of, but I think that most people believe that for pure pain, particularly back pain, the tricyclics are effective, particularly nortriptyline, amitriptyline are very famous for this. The problem is mostly side effects. It's funny, neurologists will treat with 10 milligrams. It's very interesting. They'll treat with 25 milligrams. But there's not really much evidence that over 25 milligrams that you get more and more. So if you get a great response at 10 or 25 milligrams, then that's fine. The reason that this is not good for painful symptoms of depression is that 10 and 25 milligrams are not effective antidepressant doses. So I would say for pure pain without depression, you can try tricyclics first. If they don't work, then you can try something else, which are either alpha-2 delta ligand or an SNRI. But if you have depression, alpha-2 delta ligands don't work either for depression. So probably the best treatment is an SNRI then.
There's another question here. Knowing all the specific features of antidepressants, what do you think about clinicians prescribing antidepressants?
What about it? I don't quite understand. Knowing all the specific features, what do you think about?
Maybe psychiatrists or clinicians.
Oh, well, I think that one of the problems, I have a theory about why we're seeing so much bipolar in my practice and why we're seeing so much treatment-resistant unipolar. I think the answer is that clinicians other than psychiatrists are treating all the easy cases, and what's left are these complicated cases, and they're not even really bipolar, they're kind of spectrum cases, mixed cases, difficult cases. But also, I think they're under-treating the easy cases. If you have bladder infections and you treat partially, what happens? You get resistant infections. I wonder whether that's not what's happening in medicine today, is that how many SSRIs are prescribed just in the United States? I know the answer. 6 per second, per minute, per hour, 24/7, every day of the year. 2/3 by non-psychiatrists. Many times underdosing, undertreating, too short, creating, I think, for us, treatment resistance. So I don't mind non-psychiatrists prescribing, and I don't think they should be taking care of the bipolars anyway. So I'm happy to see the bipolars. I'm happy to see the treatment resistance. I'd just rather make sure they're not manufacturing the treatment resistance for me by bad undertreatment. So partially, if they treat them well, they know how to do it, God bless them, I have no problem. My fear is that they are manufacturing my patients in my practice 2 to 10 years later by sloppy, inadequate treatment. So I think the message has to get out to treat aggressively in primary care, then I've got no problem.
I have my own questions, just a short question, because some patients generally, they come to you, they are better, but they do not recognize this. The question is, how do you deal with that? Do you use scales and questionnaires? Because when you use this, you see that the patient improved because the score decreased. But if you ask the patient the question, are you better? No, I'm not better. Do you use?
I don't use scales because I don't get paid to use scales. I'm sorry. I mean, I like it for research, but I don't use them in practice. I'm just being honest. I don't use them. I think that it's probably bad example to not use them. It probably would be better, but I think that when this happens, I use family members. The short answer to your question is find a woman. Usually the people who don't think that they're better, I need to talk to the mother, the wife, or the daughter. And I get them in, and I have an honest discussion, say, why do you not feel you're better? And listen to the other informant and find out why. and try to see if I get more information, and maybe I can convince the patient this way. Also, there may be some good reason to stay sick that is secondary gain that I'm wondering. But also, I think sometimes people are afraid of being better, and that sometimes I let them be a little bit sick, even though I know they're well, and because they're just a little more comfortable with they're sometimes afraid to be well because that means they might get sick again. So as if they're not all the way well, they won't be so disappointed when they relapse the next time. It's all the art of doing it, but there are many ways to handle it. But what I have to find out is whether it's really true, and that's by finding a woman.
There's a question here I don't really understand. I'll say that in Portuguese first and then I will translate it. Depressão refratária aos tratamentos comunicacionais, não estaríamos diante de um transtorno estrutural? I really don't understand it, but maybe refractory depression to treatments involving communication, aren't we treating structural disorders?
Maybe. Particularly late, maybe, but early, maybe not. Maybe they become structural disorders by bad treatment or delayed treatment. And but the thing is interesting. These brain scans that show shrinking hippocampus and shrinking prefrontal cortex show them growing after recovery on MRI scans when treated, probably from growth factors. So it's not hopeless if the brain has shrunk. You see the same thing in PTSD, that the hippocampus also shrinks in PTSD. And if the patient gets better from the antidepressants which make growth factors, you will see improvement in symptoms, but you'll also see the brain growing back. So it may be structural, but it doesn't matter.
Mm-hmm. Okay. The use of antidepressants in bipolar disorder, except bupropion, really shortens the bipolar episodes?
Well, this is a huge area of controversy in the world right now. And I make fun of this by saying it depends on which city you live in. Because if you live in Boston, you never use an antidepressant. Never. Bad doctor. If you're bipolar, never. No. If you're in California, you can maybe use them, but what you do is you add the antipsychotic or the lithium or the Depakote first. If they're still depressed, very, very carefully you add it on. But you never in California give an antidepressant to a bipolar who's nude. Means monotherapy. They need a fig leaf of mood stabilizer first. So in California we use them, but carefully. So I think we do that. Now in Tennessee, a good friend of mine, Richard Shelton at Vanderbilt in Nashville, he adds the antipsychotic or antidepressant first, and if he gets a problem, he then adds the antipsychotic second. So this, I call that, you know what moonshine is? Moonshine is an old-fashioned term for people making illegal liquor under the moon because they do it at night. And so I call it mood shine. Tennessee mood shine is to add the antidepressant first, because you don't know if anybody's bipolar. You give it, you go, oops! You know how, you ever done that? Oops! And so then you quickly add on the mood shine, which is add the quick mood stabilizer first. Maybe you don't stop the antidepressant. So there's many ways to do it. Tennessee, mood shine, or California careful cocktail, or a Boston bipolar brew. It's different in different cities. So I'm in California, so I add it carefully.
We have time for just one question. but there's a long question here. I'll read it in Portuguese. Kleist e Aníbal Silveira, no Brasil, falam de uma teoria de personalidade em função de um sistema cerebral com áreas de regência e suplência e das suas relações neurovegetativas. Não estaríamos nos achados neuroquímicos sem referência a uma teoria de personalidade, perdidos numa frenologia bioquímica? E a pessoa que pergunta isso agradece pela brilhante palestra, e eu concordo com isso. Let me try to translate it. Kleist and Silveira in Brazil, they talk about a theory of personality and function of a cerebral system with areas of regency and supplency. I don't know if this word exists. And the relationship, neurovegetative relationships. Aren't we two neurochemists without reference to a theory of personality lost in a biochemical phrenology?
Yes. That's why you have to practice the art, not just the science. I'm a real doctor. I give lectures. You don't believe this, do you? This is not true. The truth is a little more subtle. But it's a good question, and I think we have to be careful.
So maybe my participation finishes here, and I would like to thank Steve and Rick and all of you from Lilly for this fantastic opportunity to be here. Thank you so much.